you everyone for joining us today for this special ad hoc of our Arizona Antimicrobial Stewardship Office Hours series. Today we'll be discussing measles. My name is Kelly Kronsberg. I'll be your moderator. I'm an infectious diseases pharmacist currently serving as an antimicrobial stewardship and resistance expert within the Office of Healthcare Associated Infections here at ADHS. We have two speakers today, also with ADHS, who I'm so excited to hear what they have to say. Our first one is Dr. Neil Ampel, who's a consultant with ADHS, as well as an Emeritus Professor of Medicine and Immunobiology at the University of Arizona, and a supplemental consultant in infectious diseases at the Mayo Clinic in Arizona. His interests include coccidioidomycosis, HIV management, and diagnostic stewardship as it pertains to infection prevention and antimicrobial stewardship. He's the former chair of the Infection Control Committee at the Southern Arizona VA Medical Center and established the Antimicrobial Stewardship Committee there. He's a graduate of the University of Oregon School of Medicine, which is now known as Oregon Health and Sciences University, and completed a fellowship in infectious diseases at the Brown University affiliated hospitals, as well as a research fellowship at the University of Pittsburgh. Our second speaker today is Gwen Borlaug, who's been an infection preventionist for more than 25 years, first working in acute care before joining the Wisconsin Division of Public Health, where she served as the director of the HAI prevention program. Following retirement, she kindly joined APIC Consulting and was deployed to Washington State and Texas State Health Departments to help support long-term care facilities during the coronavirus pandemic. She then joined us at the Arizona Department of Health Services in 2020 as an infection preventionist and now serves as a public health advisor to the chief of the Office of HAI. So with no further ado, I'll hand things over to Neil.
Thank you, Kelly. So what we're going to talk about today is measles, obviously very timely, and Gwen and I were tasked with preparing this overview. I'm going to begin by talking about the clinical aspects and the background of measles, and then Gwen will follow up with infection prevention, and some of the things I will say she will emphasize as well, which I think is fine because, as the old saying goes, repetition is the essence of assertiveness. So let's see if get this going. There we go. So let's talk about measles. Historically, measles was first described as a disease about 900 in the Christian era by a Persian physician named Rhazes, but it's much, much older than that. The Latin name is morbili, which we know as morbilliform, we use to distinguish it from smallpox. It is also known as rubeola, and of course we know it as measles from the Dutch for spot or pimple. It was also called first disease, which I didn't realize. I knew about fifth disease, which is B19 parvo, but it's the first of the five exanthems that children get, and I think it deserves being the first. What is the measles virus? Well, it's part of the Paramyxoviridae family. It's in the morbillivirus genus. So this is a helical, enveloped, single-stranded, negative-sense RNA virus with the hemagglutinin and F proteins, which are antigens. It is related to mumps, parainfluenza, RSV, metapneumovirus, and the Nipah virus. Humans are its only natural host, and this is a classic of viral evolution. It's a disease of civilization. First of all, it's a zoonosis. It was likely derived from a cattle rinderpest around 500 before the Christian era. And it only became a problem when urban areas were more than 250,000 in population, which allowed a population concentration to allow spread of the disease. And that leads to the saying it takes a village, but for viral diseases where the humans are the only host, it takes a city. And that's what measles is a classic is. So once we had population centers of greater than 250,000, which was probably around 500 BCE in Mesopotamia and Eurasia, then we started to see measles. We see the same process with HIV and with other viral diseases, COVID, SARS-CoV-2, where humans are the host. Measles was first described as a clinical entity in Western literature by Thomas Sydenham, and we know him from rheumatic fever. In 1757, Francis Home was a Scottish physician who decided to mimic variolation, which was this technique of taking fluid from smallpox vesicles and inoculating them and causing immunity. Well, he couldn't get much out of the rash of measles, so he used blood. So he inoculated 12 children, healthy children, and 10 of the 12 acquired measles, and that was the first evidence that this was indeed an infectious disease. Parnham looked at the outbreak of measles in the Faroe Islands. So in the 18th and 19th century, there were multiple outbreaks of measles in island populations. Fiji was one such site, but so was the Faroe Islands in the North Atlantic. And he went there based on this outbreak. He figured out the incubation period, up to 14 days, how contagious it was, and that people who acquired this were lifelong immune. It wasn't until 1940 that O'Neill, Rake, Schaefer, and Stokes were able to cultivate the measles virus in chick embryos. And that led to the development of the measles vaccine, which was a critical development. And the story is that back in 1954, there was a measles outbreak in the Boston area. And Thomas Peebles was a pediatrician, and he partnered with John Enders, who ended up winning the Nobel Prize for isolation of polio. So he was a virologist, and they went to a young man, David Edmondson, and they asked him for blood and pharyngeal swab. David Edmondson is still alive and living in the Boston area. He he agreed to that, and they were able to grow the virus from his isolate and then passage it multiple times to attenuate it, to make it less virulent. And that was called the Edmondson B strain. From that, Enders was able to make the first live attenuated measles vaccine in 1963, and it was licensed then. Importantly, a killed version was also made that same year. And as we'll talk about, there was a problem with the killed vaccine. It caused atypical measles, resulted in both side effects and incomplete immunity, and it was removed from the market in 1968. In that same year, Hilleman further attenuated the Edmondson B virus, and he called that the Edmonston-Enders Moreton. Moreton standing for more attenuated Enders. And what's important about that is the virus that is now included in MMWR, which started in 1971, became available in 1971. So what's the results of measles vaccination? Well, we have a natural experiment. We know that prior to 1963, there were 3 to 4 million annual cases of measles in the United States. 48,000 were hospitalized, 1,000 developed encephalitis, and 400 to 500 died every year. From 68 to 83, over the next 15 years, after the measles virus live measles virus was approved, it was estimated to prevent 52 million cases, including preventing 17,000 hospitalizations and 5,200 deaths. By 2000, with the availability of MMR in 1971, endemic transmission of measles was eliminated in the United States. There were fewer than 100 cases per year, which would come out to a reduction of 99.9967% from 1963. Now, we talk a lot about doing controlled trials. This is a historical controlled trial, and I think it's a slam dunk that the MMR vaccine has resulted in, when we get a high enough vaccination rate, essentially the elimination of measles. How safe is the MMR vaccination? Well, about 5 to 15% have post-vaccination syndrome, which is self-limited up to 12 days. This consists of fever, a mild rash, soreness and redness at inoculation site, and stiffness or pain in the joints. Less frequently, you can see cervical lymphadenopathy and occasionally febrile seizures, which don't result in death or even significant morbidity. Rarely, thrombocytopenia occurs, anaphylaxis, or there's one case proven of measles inclusion body encephalitis. There's absolutely no association with autism, brain damage, or death. So what do we know about measles immunity and MMR vaccination? We know that children are protected by maternal antibody for the first 1 to 2 months of life, but that quickly wanes so that by 6 months, most children are no longer protected by maternal antibody for measles. We know that giving 2 doses of MMR provides 97% protection against measles infection. And that begins very quickly within 2 weeks of the first dose, meaning you can use vaccination as a tool for outbreak conditions. In the United States, we give the first dose of MMR between 12 and 15 months. The reason for that is you get maximal immunity. If you give that earlier, immunity is not as strong. We give the second dose at 4 to 6 years. We can give under outbreak settings, and we'll talk about that first dose at 6 to 11 months, but you still need to vaccinate with 2 doses if you do that. Now, adults born in or after 1957 are not presumed to be immune to measles. And they're certainly not if they have no laboratory evidence or they've only received 1 dose. Higher risk adults coming into that are particularly those born in or after 1957 with no laboratory immunity, and they should be given 2 doses of MMR 28 days apart. Who are these people? Healthcare workers, international travelers, students in university, household contacts of immunocompromised patients, and under outbreak settings. Now, how do we determine immunity in measles? We use immunoglobulin G levels. So an IgG level of greater than or equal to 240 international units per mil is considered strongly immune. 1 or 2 vaccinations can be considered in adults if there is evidence of lack or waning immunity, and that's particularly if you were born in or after 1957 and you're at risk. However, remember, this is a live attenuated vaccine. So there are certain circumstances we do not give MMR. First is pregnancies, because measles is associated with miscarriage, stillborn, and preterm birth. So if we were to give it in pregnancy, we would wait till the pregnancy was over, give it postpartum, and avoid pregnancy for 28 days. I'll talk about that a bit later. Patients who are cellular immunodeficient, so HIV persons who have cellular immunodeficiency as manifested by a CD4 lymphocyte count of fewer than 15%. Patients with active leukemia or lymphoma, people receiving active cancer chemotherapy, and persons with severe combined immunodeficiency. And finally, anyone with anaphylaxis to vaccine components like gelatin or neomycin. How is measles transmitted? This is the classic contagious disease. It is both aerosol and droplet, or direct contact with respiratory secretions. Surface contamination plays a minor role. The R naught, or how many people are infected from an index case, is the highest that I know, 12 to 18, meaning that one infected person will infect 12 to 18 non-immune individuals. And that's why immunity, community immunity, requires greater than or equal to 95%. Because if you don't get that, you're going to have susceptible individuals who will continue that spread. And we compare that to other common, highly contagious diseases like chickenpox. The R naught is only 7 to 10. Pertussis, 5 to 17. SARS-CoV-2, 3 to 8. And influenza, only 1 to 2. Secondarily, Measles is extremely persistent indoors. It can survive more than 2 hours as airborne droplet nuclei. So first of all, ventilation is very important, but also protection. And that's why healthcare personnel need to wear N95 masks, and surgical masks should be placed on patients with suspected measles to prevent that airborne transmission. How does measles present? Well, 10 to 14 days after exposure, there's a fever and the three C's: cough, coryza or runny nose, and conjunctivitis. And usually around the same time, 1 to 2 days prior to rash, 1 to 2 days after, are Koplik spots. These are small 1 to 2 millimeter white spots on an erythematous base on the buccal mucosa. You can see the picture there. These are pathognomonic, so they occur in 60 to 70% of cases, and they are worth looking for. So if you're concerned you have a patient with fever, cough, coryza, conjunctivitis, look at their buccal mucosa because you may make the diagnosis of measles there. The rash comes 3 to 5 days after the start of the fever. And it's classic. It's the classic morbilliform rash. It is red, macular, papular, not petechial, not scaly. But what's more important is how it starts. It starts on the face, behind the ears, the head, the trunk, the legs. So it starts up and goes down, and then as it resolves, it does that in reverse order. And you're infectious 4 days before to 4 days after rash onset. Diarrhea is very common. So don't be put off by diarrhea, and don't be put off if the rash is itchy, because it can be. So again, to go over this, we have the prodromal syndrome of fever and the three C's: a harsh, hacking, non-productive bark, nasal discharge, sneezing, congestion, and conjunctivitis, which is a pink eye. So there's bilateral redness, discharge, no corneal involvement, but there may be a feeling of grit in the eyes or even photophobia, and Koplik spots. Those are the things you want to look for, and then the rash occurs 3 to 5 days later, and again, starts on the face, behind the ears, spreads outward and downward, and starts to fade after 5 to 6 days. So the classic look of a measles patient, first of all, there's a paper called Measles is Misery. And so that you have a young child, usually less than 10 years old, who is miserable, and you look at them and they have a runny nose, drippy eyes, and they have a rash on their face. That is measles. There's a huge differential diagnosis where some of these can look the same. So you can see infectious mononucleosis has a diffuse macular papular rash, but that's associated with pharyngitis. Roseola can look like this. Rubella can look like this, much less severe. And you can see all the other differentials there. But again, measles is the only one with the three C's, and it starts on the face and goes down. And since we're in a time of a measles epidemic, it's reasonable to always keep it in the differential when you see a child with a facial rash. Now, there is also atypical and modified measles. Atypical measles is important to know. This is what happened with the killed vaccine that was released between 63 and 67, and why it was removed from market, because it actually caused more severe disease. So there would be a high fever and a rash that was atypical of measles, and there was a severe pneumonitis. So, and not only did it cause more severe disease, but immunity was less protective. There is also modified measles that occurs in people with prior measles immunity, either from vaccination or natural infection, and it's just a milder form of disease and far less contagious. Measles in pregnancy is important because it's more severe during pregnancy, particularly with regards to pneumonia. It's associated with adverse birth outcomes, increased rates of miscarriage, preterm birth, and stillborn, but different from rubella. Does not cause frank congenital infection or severe congenital infection and doesn't cause a syndrome. You can get congenital measles, which occurs during the first days of life when the mother had measles, and that can be more severe. So measles and pregnancy is a bad combination. So what should you do if measles is suspected? Gwen will talk about that more, and what she will really say is don't let that person come into a closed space. But if they're there, the first thing is to put a surgical mask on that patient and get that patient into a single private room. And if you have it, that room should be an airborne infection isolation room, meaning negative pressure with 12 or more air exchanges per hour. If you don't have that, you can put the patient into a private room that is less than optimal. Now, isolation continues until 4 days. It's actually 5 days since onset of rash is considered day zero. So 4 to 5 days after rash onset, that patient is still infectious. Healthcare personnel should wear N95 and have a documented measles immunity. And as I'll go over, the second you suspect measles, you've got to notify your local public health department. How do we make the diagnosis? The most critical way is by doing reverse transcriptase PCR testing of samples. The two most important samples are either a nasopharyngeal swab or throat swab and urine. But you can also do it with blood. The more samples you get, the higher the return. You can also use serology and particularly measles IgM antibody. Viral culture is really not available and not worth doing. So here are all the tests. RT-PCR, you can do up to 10 days of onset of rash. You can get nasopharyngeal, urine, blood, or even BAL, highly sensitive, highly specific. IgM serology should also be obtained. You can get that up to 6 to 8 weeks later, usually serum. It can have a false negative if you obtain it too early, but it can be helpful. IgG serology is really most helpful in documenting that someone has immunity to a past infection. It is not really useful for diagnosis acutely of initial disease. So, what are you going to do if you want to test for measles? You're still going to call your local health department. This is a highly contagious disease, so we want to involve them because they know there's an outbreak. But in most instances, you're not going to be able to get PCR testing on samples without assistance from your county health department. You should be able to obtain IgM and, if you wish, IgG serology through commercial labs. But for PCR testing, you should be going through your local county. Importantly, to obtain a nasopharyngeal swab, use a polyester fiber tip synthetic swab with a plastic shaft. Do not use calcium alginate or cotton swabs. Put it in viral transport media and refrigerate. And then the health department will let you know. You can either do this if you have the patient, you can obtain the sample and put it away, and I would also obtain a urine sample, or if the health department answers within a reasonable time, you can then get the sample. But either way, you can get those samples, store them, and the health department will decide if it's reasonable to go on and test through the Arizona State Public Health Laboratory. So, measles is a severe disease. It starts out with the prodrome, the first 4 to 5 days, but after a week, we start to see a lot of complications: chronic diarrhea, pneumonitis, conjunctivitis with keratitis, otitis media, and encephalitis. So you can see this can result in malnutrition, pneumonia, blindness, and secondary infections and encephalitis. So this is not a benign disease. And one of the reasons for that is how natural measles interacts with our immune system. It uses the ligand CD150 that targets B cells and memory T cells and causes a temporary immune amnesia that can last up to a year. and reduces innate and adaptive immunity. And this is distinct to what measles vaccine immunity. That goes through CD46. So no immune amnesia, and so we do not get all these other consequences. And Nectin-1 is the receptor that causes the pneumonitis. So here are all the complications we see. This is from the recent New England Journal of Medicine review, but I'm going to go through them on this slide. First of all, hepatitis, leukopenia, and thrombocytopenia are common during acute disease. And complications in any unvaccinated measles patient occurs in about 30% of individuals. Pneumonia is the leading cause of hospitalization and mortality. It may be either directly due to measles virus or it may be bacterial, say from pneumococcus, staphylococcus aureus, or Haemophilus influenzae. Another group of patients get otitis media. This is not benign. It can result in deafness and keratoconjunctivitis, not commonly seen in the United States. First of all, this is different than the conjunctivitis of the prodrome, which is really a pink eye that rapidly resolves. This is a keratitis that causes corneal inflammation, and as you can see from the photograph, that can result in blindness. This is more commonly seen in children who are malnourished and have vitamin A deficiency. Patients also frequently have diarrhea that can result in malnutrition. And finally, CNS complications. There are three kinds of encephalitides that one can get from measles. One is direct and acute. That's acute measles encephalitis. Occurs about 2 weeks after rash onset, 1 out of 1,000. Headache, vomiting, stiff neck. If we do a lumbar puncture, we're going to see pleocytosis and PCR positive for measles virus in the CSF. Acute disseminated encephalomyelitis is an autoimmune phenomenon, but it occurs at the same time period and about the same frequency with similar symptoms. The difference is CSF shows minimal pleocytosis and PCR for measles virus in the CSF will be negative. And finally, subacute sclerosing panencephalitis only occurs in about 1 out of 25,000 cases, but has a higher frequency in children less than 5. This may occur years after initial infection with mood disturbances, hyperactivity, cognitive decline, and monoclonal seizures. So how do we manage measles? We only have supportive therapy. There are no approved antivirals, although some clinicians have used ribavirin and fewer still have used interferon alpha. Most, it's just supportive care. What's the role of vitamin A? Measles infection results in low vitamin A levels, and pre-existing low vitamin A levels predispose to more severe disease. So in the United States, vitamin A supplementation is recommended, and you can see from the chart there from the New England Journal of Medicine article how to supplement. But importantly, there is no role for vitamin A to prevent measles, as was done in the Texas outbreak. All that does is cause vitamin A toxicity. So we would only use vitamin A in children with severe measles, who have measles. Just to go over exposure, and again, Gwen will go over this, because of this high R naught, just sharing the same room or airspace with the case is an exposure, and that can be up to 30 meters. So that's a waiting room or a waiting area at a gate at an airport. There is no minimum time of exposure. Gwen and I were talking at the recent APIC meeting. Maricopa County uses 15 minutes. That's an epidemiologic tool. Technically, if you're in a room with someone with measles, you've been exposed, and if it's more than 30 minutes, that's a very high risk exposure. And you're definitely at risk if you lack measles immunity. You had fewer than 2 doses of MMR, you have no laboratory IgG level, or you have no prior measles history. And if you have that, public health may want to quarantine you for up to 21 days. Remember, the incubation period to time of fever is 10 to 14 days with that rash occurring up to 5 days later. So that's why that 21 days of quarantine is requested. What are we going to do if you've been exposed? We have two options. We have passive immunization with immune globulin. This is routine gamma guard, not anything hyperimmune. And you want to give that within 6 days of exposure. We're going to do this particularly for three groups. We're going to do it for infants at less than 6 months of age, up to 12 months. Why? Because they don't respond well to MMR. We're going to do it in pregnancy because we don't want to use a live vaccine during pregnancy, and the same with immunocompromised patients. We don't want to use a live vaccine in either of these three groups. And those are the doses of immune globulin that you can give. In other groups, we can do MMR vaccination. This should be done within 72 hours of exposure. Because as I've mentioned, within 2 weeks you can have protection. So we're going to do that for children and older than 12 months and adults. And you can see the rules where we're going to do it basically if they're non-immune. We may also do it for infants 6 to 12 months. If you do that, don't give immunoglobulin because you're going to blunt the result of the MMR. And you still need to give 2 subsequent doses of MMR after you've given that single dose. Now I want to go over outbreaks. So as I mentioned, 2000 we had eliminated measles, and then in the 2010s to now, we started to see sporadic cases, and these were due to incidences of locally low measles immunity. If we look at charts, we see that measles immunity in the United States was close to 90-95% up to 2020 when COVID started. But we still would get these focal outbreaks, and this one in 2018 is a great example. This occurred among the New York Orthodox Jewish population in Williamsburg. The source was an unvaccinated child who came back from Israel with a rash. It ended up causing 649 confirmed cases that went on for months. You can see 86% of those involved were unvaccinated. The median age was 3 years. It resulted in 49 being hospitalized, 20 to ICUs. Fortunately, no deaths. And of those who were admitted, 95% were unvaccinated. And transmission occurred everywhere. Finally, control measures started about 6 months in, 20,000 contacts receiving MMR, immune globulin, and home quarantine. Almost 200,000 doses of MMR were given. They finally got the vaccine rate up from 79.5 to 91%, and that cost 8.4 million. So that was a result of one outbreak where a local community was under-vaccinated. But now, since 2025, we're seeing multiple outbreaks. West Texas, New Mexico, Utah-Arizona border, South Carolina, and also now Florida. And so over the last 2 years, starting in 2025, we've started to see more and more cases. Why is that? Well, if you look at vaccination rates during COVID, they dropped dramatically down below 80%, and they've never recovered. So we did okay in 21, 22, 23, and 24, but 25 and 26, we began to see measles outbreaks. And this is a nice graphic showing what we've been going through. The first outbreak was the West Texas outbreak, which began January 20th, 2025. That eventually ended in mid-August, but then in early June, we have the Utah-Arizona outbreak, which is still smoldering on. And then in October of 2025, we started to see the South Carolina outbreak. This is from Saba Kazmi, who just presented this at Arizona Infectious Disease Society. This is the cases from Mojave County. Remember, there are a similar number of cases right over the border in Hilldale in southwestern Utah. So this is a double state outbreak. But the South Carolina outbreak should really give us pause. This started on October 2nd with the identification of 5 cases in Spartanburg County. You can see that they're in northwestern South Carolina. And then they saw 2 additional cases in 2 schools. One school was a charter school where the vaccination rate, the MMR vaccination rate, was 21%. But even in the public school, it was 82%. So you can see how quickly this increased. This graph is up to January 25th, but I can tell you as of late February, this has continued on. It may be starting to ameliorate now, but over 1,000 cases now. And you can see how fast this spreads in a population that has low vaccination rates. So, in conclusion, measles is highly contagious and you need greater than 95% community immunity to prevent the spread. 2 doses of MMR is 97% effective in inducing individual immunity and also highly effective in preventing outbreaks. Measles can be suspected clinically by fever, the 3 Cs, and complex spots, followed by a rash that starts on the face and spreads downward. Testing entails RT-PCR of throat, pharynx, and urine, and serology, particularly IgM. Patients with suspected measles should be placed in respiratory isolation, and healthcare professionals should wear N95 masks and be measles immune. 30% of healthy individuals who are non-immune will have complications of measles, including pneumonia, hearing loss, blindness, malnutrition, and encephalitis. There's no specific treatment for measles, but vitamin A supplementation may reduce complications, but doesn't prevent measles infection. And finally, multiple measles outbreaks are currently occurring in the US, and that's because of failure to vaccinate, not failure of the vaccine. So I'm going to turn it over now to Gwen.
Thank you, Dr. Ampel, and thank you for all this, that you advanced the slides for me. So
You're
we're going
welcome.
to now switch to infection control in healthcare settings. Next slide. And what I want to do is point to you our ADHS measles resources. If you click on that link, you will see a whole list of other resources that you can use that I think are very helpful. I want to point out that we have a couple of new resources. One of them is the ADHS FAQ on managing measles exposures in healthcare personnel. This will give you definitions, for example, what are healthcare personnel, what is an exposure, and how outpatient settings can help prevent measles exposures in their staff. The second is an FAQ regarding preventing and controlling measles in healthcare facilities, and that contains both Arizona state and federal requirements of infection prevention programs, as well as state and federal recommendations. So also a very important and helpful resource, we hope. So my talk today, we're going to summarize highlight some things from the ADHS Measles Surveillance Toolkit for Healthcare Settings, which was just updated a couple weeks ago, and I think is just your one-stop shopping for what to do in response to measles. And so I would point that to you. If you haven't reviewed it, please do so. And then also we'll talk a little bit about the measles website, or ADHS measles website, the outbreak data, where you can get up-to-date information on our current outbreak. And then I'll touch on just a little bit to point you to the CDC Measles Preparedness and Response, which has a couple of really good tools for helping you make sure that you are ready for a measles case. Next slide. So this is an example. If you click on the data for measles in Arizona, local health departments will notify and put up public notices on their website when there has been an exposure in the community and they are unable to determine who exactly was exposed, so that they may not be able to contact everybody. And so they put up these notices to let the public know that they may be exposed and that they should watch for symptoms if they were at these places during this time. This is an example of what Maricopa County had up on their website when there was an exposure at Phoenix Sky Harbor, and there was no way that they could figure out who might have been present during that time. So this is what is very helpful. You can find out what's going on in your county as well by looking at these public notices. This one has expired, of course, and I don't think there's been any public exposure since then, but that's just an example. Next slide. So when we talk about measles prevention in healthcare settings, I divide it into two basic arms of prevention. One is a proactive vaccination program, which is our most effective tool. This is our best weapon we have in our arsenal. And the next one is infection control. So we're going to talk about those two big arms of prevention. Next slide. So in the measles surveillance toolkit, there's this very important statement, of course, that says the most effective way to prevent measles transmission, of course, is through vaccination with an measles-containing virus. And I've put a link here for the CDC recommended adult immunization schedule. If you look at that, it recommends that anybody who does not have immunity, any adult under age 68, that they be vaccinated if they'd have no contraindications to the vaccine. So that's, again, if born before 19 or born after, during or after 1957, really consider like your residents in your long-term care facilities or your healthcare workers that they receive the vaccine if they don't have any evidence of immunity. Next slide. So what is evidence of immunity? Well, this is a nice table from the surveillance toolkit that talks about what do we mean by presumptive immunity for healthcare personnel. You will notice that it is more specific for healthcare workers than it is the general public. So for healthcare workers, if they have written documentation of 2 MMR doses administered appropriately 28 days apart, that counts as evidence of immunity, as well as if they have laboratory evidence of the disease or laboratory evidence of immunity. So if they have those 3, then you can consider that they are immune. For the general public, if they are born before 1957 or have just 1 dose, we can consider them as immune as well. Next slide. So we've had questions about, well, what do you mean? What is a healthcare worker? Who do I have to make sure it has immunity? We go by the CDC definition, which is those who are working in healthcare settings who have potential for exposure to patients or infectious materials. And that includes people outside the pre-hospital, post-hospital, so that's your EMS personnel, nurses, nursing assistants, anybody who's going to come in contact, again, with patients or infectious material. And this is particularly important for measles, that your clerical staff, your dietary staff, those in ancillary departments certainly can have exposure to patients with measles. So those are also included in those people you want to make sure have immunity. Next slide. I want to highlight some footnotes. We want to look at special considerations for healthcare personnel. Again, those vaccinated between 1963 and 1967 with that inactivated measles vaccine that Dr. Ample spoke about, those individuals should be revaccinated with the doses of the live attenuated MMR, spaced at least 28 days apart. The healthcare workers who've had 2 doses, we just want to make note that you do not need to perform serological testing for immunity. They have had those doses. That's evidence of immunity, so do not bother testing them. Sometimes they will come out negative even though they've been vaccinated. That's because the antibody does wane, but if they encounter a measles patient, they will have sufficient response, immune response, and those antibodies will come right back up to effective levels. Sometimes, again, if you get negative results, then you think, well, what do I do? You do not need to vaccinate. So don't bother to do the serological testing. especially during an outbreak. You don't want that serological testing to delay vaccination. Next slide. So for those, if you're reviewing your documents, your employee health records, and to make sure that all of your staff are immune, which I would highly recommend if you haven't done so already, you want to offer, it's really recommended to offer that vaccine at no cost to them to break through any barriers that they may have. You want to make sure that they get those if they don't have any evidence of immunity. If, again, if they only have one documented MMR, remember that's not good enough for healthcare personnel, so they should receive that second dose. And then we often get this question, recently vaccinated personnel, do we need to keep them off work because are they going to shed the virus after they've been vaccinated? And the answer is no, they will not shed that virus even though they've been vaccinated with a live attenuated strain. So they do not need to have work restrictions. They can go right back to work after being vaccinated. Next slide. So now let's look at measles infection control with the 3 I's: identify, isolate, and inform. There is a link at the bottom to CDC's Project First Line MicroLearn. This is a nice little flyer that summarizes these steps. I think it would be especially helpful for your frontline staff. They're going to be heavily involved in identifying. They're kind of the first line of defense of what to do when a measles case comes into your facility. So we want to make sure that they are following the steps, that they will be able to let somebody know what needs to be done, manage that patient at the beginning so that they get isolated into a room as soon as possible. So again, we're going to assume a patient has measles if they have those symptoms that Dr. Ample spoke about, and that they have these epidemiologic risk factors, that they spend time in an area in the country with an outbreak, that they were with somebody else who had measles, that they traveled internationally in the last 3 weeks and have not been vaccinated for measles, or you can't find out what their vaccination status is. So if your facility is located in an area of the state where measles is spreading, anyone with measles symptoms should be considered to have measles until you can rule it out. So that level, that index of suspicion is very high, and you want to manage them accordingly. Next slide. This might be helpful for those of you that are in ambulatory settings or have urgent cares. If somebody calls in to your ambulatory setting and you suspect they have measles, you're going to instruct them as to what to do. But if they're walking in without calling you, say to an urgent care or your clinic or to the ED, it might be helpful to have this sign or a sign like it to give instructions. If you have these symptoms, here's what we want you to do. We want you to stay outside and call us, and we'll give you further instructions, just to be able to keep them outside until you are able to respond appropriately and let them into your building safely. Next slide. And then the next I is isolate. So when you have a patient suspected of measles coming into the healthcare setting, as Dr. Ampo said, we want the patient to call upon arrival, remain outside until they're escorted in, because you want to take them through a route in your facility where they're not going to expose other patients or healthcare staff. They should be given a mask to wear immediately, taken to an AIIR room if you have that available. If not, you're going to place them in a private room with the door closed, and anybody entering that room is going to don an N95 respirator. And if you have healthcare personnel who do not have evidence of immunity, they are not going to be allowed to go into that room. You want to instruct the patient, if you send them home then, on how they should self-isolate. But also, as you know, you're going to call the local health department, and the local health department will be the ones to instruct on should they be isolated, how long should they be isolated, and other infection prevention measures that they may be able to practice at home. But the local health department, of course, is the one that has the authority and the responsibility to require them to either to isolate at home or to quarantine contacts. Next slide. We also just want to remind that in addition to airborne precautions for measles patients, to follow standard precautions. Those are always in place. So hand hygiene, environmental cleaning and disinfection, and use of PPE when exposure to blood and body fluids and non-intact skin is anticipated. The good news when we talk about environmental cleaning and disinfection when it comes to measles, it is an envelope virus, so the usual hospital grade disinfectants that you have in your facility will be sufficient. You do not need any particular special disinfecting agents. Next slide. And finally, to inform, again, we really want to emphasize, if you know you're having a suspected case of measles coming into your facility, call your local health department right away. Be prepared to collect the appropriate specimens. And if you are going to submit them to the state public health lab, of course, you need that permission to do so from your local health department. And what I would emphasize is if you have not had a conversation yet with your local public health department, if you haven't had any measles cases or suspected cases in your facility, now would be a good time to really get together with your local public health department and just plan in advance and review those steps, how the two of you are going to collaborate together so that you can be ready and know exactly what to do, exactly who to call when you do have a case coming in. Next slide. So what is an exposure? Dr. Ample did talk about that. In a healthcare setting, it's defined as, again, spending any amount of time while unprotected. If your staff member is not wearing an N95 and they were in shared airspace with an infectious measles patient at the same time, that would be an exposure, or in a shared airspace vacated by a measles patient for up to 2 hours. But again, we want you to let your local health department know that there's been a patient in your facility that you suspect has measles, and talk to them about how if your healthcare worker needs to be excluded and for how long, and monitoring for symptoms and so on and so forth. So again, you're going to be working very closely with your health department when these occur. Next slide. Dr. Ampel talked about this, so I won't really dwell on this. Post-exposure prophylaxis, either the vaccine or for those who are not eligible or have contraindications to the vaccine, it would be the immune globulin. For those healthcare workers then who are immune, have immunity, they're not going to get post-exposure prophylaxis, but you're going to want to monitor them for symptoms through at least one incubation period. They can continue to work if they have immunity, but they should be monitored for symptoms. For those who do not have evidence of immunity and received one form of post-exposure prophylaxis, our surveillance guide in that toolkit says regardless if they were given PEP, even if they were given PEP, they are going to be have to be excluded starting on day 5 through day 21 after their last known exposure. So again, that's when in our ADH toolkit, but again, you can contact your local health department just to see if they have other protocols that you should be following instead. Next slide. Finally, I just want to point out, again, CDC has a great measles preparedness toolkit that includes a measles assessment tool, which is really fantastic. You can do a self-assessment of how prepared you are because it talks about all the components of your response, including what you see listed here, so that you can bolster those preparedness plans if you need to. I just really recommend this. It's a really great way of making sure that you're prepared in your facility. Next slide. Also in that toolkit, it has responding to measles exposures and sample scripts. But again, just make sure that you are in tune with what your local health department protocols are, that you're prepared for that, and that you're in great communication with them when you have cases and exposures. Next slide. And if you have any questions about measles and measles response, you can contact us at this email address. And that is all I have. Kelly, I'll turn it back to you.